Hello, dear colleague. Welcome to this session devoted to vascular access to RT and CRT. I'm Professor Patrick Honoré from the CHU UCL Montgadin from Belgium. And my co-presenter is Professor Thomas Rimmele, ICU in CHU from Lyon. I have first some good news for you. Because we will have 40 minutes, not 30 minutes. So that will leave us with 15, 20 minutes of presentation by my colleague, Professor Thomas Rimmele, and leaving 20 minutes, something like this, for discussion. So please ask as many questions as you want, okay? So 40 minutes instead of 30 minutes, okay? Good. Right. I leave now all the microphone to Thomas.
Okay, good morning, everyone. So during the 15-20 minutes, I'm going to review with you all the different characteristics of renal replacement therapy catheter. And then after, Patrick and I will respond to all your questions. So this is, first of all, general information. You must know that the dialysis catheter is the primary cause of alarms on a dialysis machine. Okay, so that's very important to understand that you have to manage correctly the dialysis catheters in the ICU if you want to stop all these alarms. If you have a good dialysis catheter and a good dialysis catheter management, if you manage correctly the catheters in the ICU, then you're going to have a session of CRT which will be very stable. Because you can claim that you do CRT in your unit, but if every 15 minutes, 30 minutes, there is an alarm and then your machine stops, this is not continuous renal replacement therapy, right? So this is very important to understand that if you manage correctly your catheters, then you're going to do really continuous renal replacement therapy. And then, if you do so, the gap between the administered dialysis dose and the prescribed dose will be very much reduced. Do you know that when you prescribe a dialysis dose, your patient doesn't get this dose, right? Do you know that? This should be very interactive. Huh? So you tell me. It's like if you prescribe an antibiotic like tazocillin, 12 grams or 16 grams, right? Your patient is going to get this amount of tazocillin. But if you prescribe 30 or 35 ml per kilo per hour of effluent dose of renal replacement therapy, your patient is not going to get 30 to 35 ml per kilo per hour. He's going to get what we call the administered dialysis dose, which will be around 25 ml per kilo per hour. Because there is this gap. Why there is a gap? Because you are going to do a little bit of nursing of your patient 2 to 3 times per day, right? At that moment, you're going to put your machine in a safety mode, like only the blood pump is going to run. So you're going to lose a little bit of dose. Also, your patient is going to go to the CT scan, is going to go to surgery maybe. And then, so you're not going to dialyze your patient at that moment. So you're going to lose again a little bit of dose. And then sometimes, because you don't manage correctly your dialysis catheter, then you're going to have to change the catheter, or you are going to deal with problems with the catheter. And that's why we are here, because we don't want these stops. Okay, do you understand? Any questions so far? It's okay? So first of all, which law drives the use of the dialysis catheter in your unit? Anyone can tell me? Who wrote the law like a long time ago?
Laplace? Laplace?
Laplace?
Yeah.
No, not Laplace. No. Not really Laplace. Well, that's the Poiseuille law. Do you know this law? Right? You've heard about this guy. Jean-Léonard Poiseuille was from the 19th century in France for the Polytechnic School, 1815 promotion. At that moment, he did not write this law. He was working on hemodynamics, but anyway. And then he found that hemodynamics was too easy, so he said, I'm going to write on something else. I'm going to work on the law that drives the circulation of the blood inside a catheter. And what did he write? He wrote that the blood flow inside allowed inside the catheter is directly a function of the diameter of the catheter. But with the number 4 here, I don't know if you see here, the number 4 is very important because it means that if you increase a little bit the size, the diameter of your catheter, you are going to increase very much the blood flow allowed inside the catheter. And it's divided by the viscosity and the length of the catheter, which is very important because it means that if you want a high blood flow rate, you cannot use a too long catheter, right? Short catheters are better if you want a high blood flow rate inside the catheter. That's the Poiseuille law, okay? Any questions regarding Poiseuille law? It's fine? Okay, so where do you insert your dialysis catheter? Well, we don't decide by random, but we have to follow the KDIGO guidelines, the international recommendations. What do they say? They say that we want the tip of the catheter located in a high blood flow rate location. So where do you have a high blood flow rate location in your body? At the entrance of the right atrium, right? This is where the blood flow is the highest. So to reach this zone, you have the first possibility is to put your catheter in the right jugular vein, right? And it's very good because you can reach the right atrium only 15 centimeters. But if this site is not available, then you are going to place your catheter in the femoral site. But then you need a longer catheter to reach the inferior vena cava. You need 25 centimeters. Sometimes there are some mistakes done. You put the dialysis catheter on the femoral vein, but it's too short, 15 centimeters. That's not good because you don't reach the inferior vena cava, and so your blood flow, the blood flow there is not very high. So you won't be able to take the blood from the circulation. So femoral is 25 centimeters. And then if it's not possible also in the femoral site, then you go for the left jugular vein. And then here you put a 20 centimeter catheter. Right? That's the international recommendation. So it should be followed like this. And this is based on studies, of course, but I'm not going to present all these studies, but randomized control studies like this one, reporting that in the left jugular vein, if you place the catheter in the left jugular site, then you're going to have more problems with your catheter than if you put in the right jugular vein or in the femoral site. Okay? This is based on evidence-based medicine. It's not because one day some guy said we should start with the right jugular vein. It's based on evidence-based medicine. Which diameter? Do you put 13 French, 14 French, 15 French? How do you do in your unit? You have to think about it. You have to know the size of your diameter. Of course, we said before that the bigger size, the higher the size of the diameter is, the best your blood flow can be, right? So actually, it depends on your modality. Actually, if you use CVVHD in your unit, you can use a low blood flow rate because with CVVHD you don't necessarily need to go over 150 ml per minute, right? You can use a low blood flow rate, so you don't necessarily need a huge catheter in terms of diameter. But if you use CVH, you have to pay attention to your filtration fraction. That means you need a higher blood flow rate, so a larger catheter. If you use intermittent hemodialysis in your unit, then you will have even higher blood flow rate because you can go to 250 ml per minute or even 350 ml per minute. So that means you need even bigger blood flow rate. And of course, if you do echo, then you need even a larger catheter. So actually, it depends on your modality. In my center, we use a lot of CVVHD and intermittent hemodialysis. So we start with the catheter with 13.5 French or 14 French. We don't change, of course, from when we switch from CVVHD to intermittent hemodialysis, we don't change the catheter. We start, of course, first with our catheter from 13.5 French or 14 French. Okay? Do you know what catheter recirculation is? Right? That's very important. What is catheter recirculation? So you have your catheter here in a high blood flow rate location. The high blood flow rate location is represented here by the blue arrows. You have a lot of blood circulating. The blood flow in the vessel here is high. Okay. Then you have the entrance of the blood in the proximal hole, right? So the blood is going inside the catheter. And then the blood is dialyzed in the machine. And then the return is on the distal side, distal hole. And then when the blood exits the catheter, is pushed, right? Pushed away, because we are in a high blood flow rate location. That's why it's important to be in a high blood flow rate location. Recirculation is this small amount of blood going again in the dialysis machine. This you don't want. You don't want recirculation because you are going to lose a little bit of efficacy of your session. But there is always a little bit of recirculation, below 5% in normal conditions. But if you are not in a high blood flow rate location, then the blood is not going to be pushed away when it exits. So recirculation will be higher. So if you put your catheter not in a high blood flow rate location, recirculation will increase. In which other condition there will be a lot of recirculation? You have any idea? When you do something on your circuit which is not good and you know it, but then you still do it.
When we switch the arterial
Yes,
and the...
very good, exactly. To switch the line, right?
Sorry?
Switch the lines. You know it when you do it, but we still do it. Why? Because it's going to fix some pressure problems. So when we are going to switch the lines, the blood is going to enter here, right? And exit here. So, of course, recirculation will be increased to 45-50%. It means half of your blood, which is cleaned, is going to go again in the circulation, in the dialysis machine. It's like you put your clothes in your washing machine, you get your clean clothes, and then you take it, put it again in the machine. Do you do this at home? Now, we don't do it because we lose a lot of efficacy, and we don't want this, right? So we don't want to switch the line. It's not the good thing. So how to limit recirculation? We have to have a distance. We are going to show you some samples of catheters, so you can see. We need a distance between the two holes of the catheter of 2 to 3 centimeters. We need a high blood flow rate at the site of the tip, and we do not reverse the lines. Okay? So if you put a femoral catheter which is with a length of less than 20 centimeters, you see that recirculation is drastically increased because you are not in a high blood flow rate location. So which design? So now you can see the different, we have some samples here. So you can see the different designs. First, you have the design inside. So what we want inside the catheter is we want a laminar flux. This is very important because we don't want turbulent flux. What is turbulent flux? It's when the blood is inside the catheter is going with a turbulent flux. Turbulent flux means thrombosis. Okay? If you have turbulent flux, you have thrombosis. So, of course, you don't want thrombosis inside the catheter. So, you have turbulent flux when you have angles here inside. Okay? If you have angles, you have a lot of turbulent flux, which means thrombosis. So actually, coaxial catheter, you are going to see that. Coaxial catheter, a lot of turbulent flux here. So it means thrombosis. You have also double O catheter, okay. No turbulent flux, but the diameter, the external catheter, external diameter is very big. The ratio of internal diameter and external diameter is not so optimum. Here, double D, we have also a double D, I think, circulating here. A double D also some angles, which means turbulent flux. So actually the best catheter is a cycle C or kidney shape, and you have some catheters circulating. You can see that. No angles here, and optimization of the two diameters, internal diameter and external diameter.
Okay.
Okay?
Shotgun here. Okay.
So you have the design of the internal lumen, and also you have the design of the tip, of the catheter. Okay. So these, some of you they have this kind of catheters. We call this the pointed catheters. Do you have this?
You're looking to the.
Anyone have?
What do you think?
No? No one? Actually, it's good because it's not a good catheter. The pointed catheters here are not very good. Although the fellows, they love these catheters. Why? They love because it's easy to insert inside the body, right?
This is the one? Yeah.
So these catheters, easy to insert, but what's the problem with these catheters? What's the problem of these side holes? I've used, when I was a fellow 25 years ago, I was using these catheters.
Okay.
What's the problem with these side holes? This is the entrance hole, the proximal holes. You have a lot of turbulent flux. And then there's going to be a lot of clotting here. And by the way, if you remove these catheters, I remember when I was removing the catheters, I was looking at the catheter, all the holes here were clot, right? Because of the turbulent flux. So if you still have these catheters, you should change for this catheter, which is the shotgun catheter. Shotgun catheter is the recommended catheter at this time. Sometimes you have this problem. But the nurses, I don't know if we have nurses here. Any nurses? If we have nurses, they know very well how to, switch to get this position. Do you use impregnated catheters with like anticoagulant or antibiotics on the dialysis catheter in your unit? I don't think it's a good idea. No one, it's not recommended for the ICU. It may be okay for, in a chronic dialysis field for some specific patients, but in the ICU, the duration of the catheter is not very long, so we don't use impregnated catheters with antibiotics or antithrombotic. This I'm gonna switch to now should we use catheter? Do you use catheter locks? Okay, so imagine you have your patient and you send your patient to the CT scan or to the surgery. You go send the patient to surgery for a few hours. Do you put a locking solution? What's your practice? Yes?
I said yes.
So citrate, heparin, saline.
We also use citracetaat.
That's a very good point. Yeah, so I think it's good. It's important to place a citrate.
Depends.
Yeah, go ahead.
It depends whether we start the hemodialysis soon or we will postpone it later.
Let's imagine you send your patient to the theater for surgery.
For surgery.
Like for 3 hours, 4 hours.
I think we will.
No. I think now it's good to put a locking solution to avoid any thrombosis while the patient is in the operating room. So the answer is yes, and it's actually demonstrated that the locking solution is better with citrate as compared to saline. The locking solution should not be saline. Citrate locks and heparin locks are better than saline solution, demonstrated in this study. And so to conclude, before we discuss together, because it should be an interactive session, to conclude, I would say that the optimal diameter should be according to the modality, from 12 to 16 French. The optimal shape for the internal lumen cycle C catheter. The distal tip should be shotgun catheter. You should go first for the right jugular vein, and then, if not possible, you go to the femoral vein. You avoid the left jugular vein, and you avoid the subclavian site, of course. Subclavian site is not recommended. You do not reverse the lines, okay? You use ultrasound guidance, of course, to place the catheter. You use biocompatible material, but this is what we have now in our units. If you put the catheter in the internal jugular vein, then you should check the position with the radiography, and then you also need to put a locking solution when you stop the use of your replacement therapy. Okay, so now we are going to answer your question, right?
Thank you so much, Thomas, for this great tour de force. So, question here, please.
Thank you, Dr. Thomas. Two questions, actually. One about accessory ports. A third port for infusion, for medication. Does it worsen the performance of the catheter, and if there is any drug that you should not infuse on the third line? And the other would be if you have a one-directional valve, they use it on chronic hemodialysis to avoid locking. If there is any data on acute setting, because we use them from Brazil. We have used it there with no data, and our experience on critical care patients is no good. You lose catheters, I think, prothrombotic, and it's different from the chronic failure.
Okay, I was expecting your question. Okay. So the 3-lumen catheter, there are pros and cons, as always, right? So the pros, I think it's, of course, when do you want to place a 3-lumen catheter? Is when you have difficulties to have access to other sites because your patient doesn't have easy access to different veins, or the other sites are occupied by central venous lines, or I don't know. No, because of course you can infuse your patient, but it's when it's difficult to infuse your patient. That's when you want to use this 3-lumen catheter. Also, it could be interesting in some protocols when you use citrate anticoagulation, the calcium administration can be done on that lumen, because then half of your catheter will be anticoagulated in this situation, right? If you place the calcium administration on this 3rd lumen, I think there is one catheter here. Where is it?
Yeah.
Oh, here.
That's okay.
Sorry. Yeah, we are going to show you this 3-lumen catheter. You can infuse the calcium on this 3rd lumen, 3rd line. So is your catheter anticoagulated with citrate anticoagulation in this situation? Actually, half only. Only the return, not the entrance lumen is not anticoagulated. Because sometimes I hear that if we do this, if you return your calcium on the 3rd lumen, your catheter is anticoagulated. This is true only for half of the catheter. It's very important when you use citrate anticoagulation to have a very good catheter, because there is no anticoagulation in the catheter when you do citrate anticoagulation, right? It's only regional anticoagulation. In the past, when you are using heparin, the entire body was anticoagulated, including the catheter. But with citrate anticoagulation, catheter is not anticoagulated. So you need a very good catheter. And actually, it's very funny because when you go to a unit, they say, oh, wait, last year we switched for citrate. Thank you so much. It's very good. We are very happy with citrate. But sometimes you go to a unit, citrate, we are very disappointed with citrate. Sometimes you find this kind of teams in some countries. Each time you have this, I guarantee it's because they don't use correct catheters. They use a bad catheter. And with heparin, it was okay, a little bit. But then they switch for citrate, and then it's a disaster. Because the catheter is not good. It's a pointed catheter, But if you have, that's why it's very important when you start citrate anticoagulation to manage correctly your dialysis catheters, because your catheter is not going to be anticoagulated. And if you put on the third line, only half will be anticoagulated. And the pros, I don't know if somebody's talking. No, it's outside. And the cons, what is not so good with this catheter? Well, I was talking about the ratio of the internal lumen and the external lumen. If you have a third lumen, of course, the ratio is going to be a little bit compromised, right? From the internal lumen and the external lumen, because you need 3 lumen. So that's a negative point. And also, some of the drugs, if you infuse some of the drugs in the third lumen, they are going to be dialyzed, of course. Yes?
Can you use vasopressor in the third lumen?
Sorry?
Can you use vasopressors in third lumen?
Yes, you can. Yeah. You can use vasopressors on this line, and I know some people doing it. You have to know that it's okay. Some of the norepinephrine is going to be going in the machine and lost, but it's not so important because you can adapt. And some people claim that the half-life of this vasopressor is so short that it's not so important. So of course you can use vasopressor on these lines.
This is true because there was a study by Rinaldo Bellomo showing that 99.5% of the catabolism of the noradrenaline, adrenaline and so forth is done by the body itself. So nothing to do with the, let's say, deviation through the catheter. So no worry at all. Yes?
Just a quick follow-up on so if you're infusing your calcium for citrate through that third lumen, do you then have to give more calcium? Are you going to lose some of your calcium replacement? No.
Oh, no. If we use, it doesn't impact your protocol of citrate calcium return if you place your catheter here. I don't think it will change very much your catheter, your protocol.
The only thing is obviously if you use gluconate or chloride. So if you use gluconate, then you can put in a peripheral line. That's possible. If it's chloride, obviously not. But then you have to change because the concentration is not itself, the self. And if you have a shortage of chloride, calcium chloride, you have to be ready in the night, in the weekend, to translate immediately what kind of level of calcium you would need if you have to use gluconate.
So we still have 10 minutes for questions. If you have some points you want to raise about your dialysis catheters, we are very happy. I didn't answer your question about the one direction.
In Brazil, the device name is Tego. It's a cap that you put. It's one directional, and it says that you don't need to put citrate or heparin or no lock. It's just saline.
Yeah, I've never seen these catheters in the ICU. It's only for chronic patients, I think, right?
Yes.
Okay. Are you all using shotgun catheters and cycle C catheters now? Because more and more, I think, in what I can see from different colleagues around the world. It's always now. I think it's a practice. Yes, this is what you all use. Do you, some of you they don't know what you use? Or you? No.
By the way, you are right internal catheter. It's a 15 centimeter catheter, and you do the chest X-ray, and it's spending 2 centimeters in the right atrium. Is this a catastrophe or not? Or is it perhaps better for the flow? Who wants to answer? Let's say we're going to vote. Who says it's going to good thing? Raise your hand. Okay, almost nobody. Who is going to think it's going to be a bad thing? Raise your hand. Okay, that's the majority. So just explain to me why it should be a bad thing.
Catheter natrium is not a good position.
For what?
For patient.
Yeah, but for which risk?
So why is it? Why do you believe it's not so good to place the tip of the catheter inside the right atrium?
Thrombosis.
There will be no thrombosis. The flow inside the right atrium is very high. It's like the same at the entrance. So it's not because of thrombosis.
In fact, if I may, you have a huge study done by the Australian randomized control trial comparing the tip of the right jugular catheter inside the superior vena cava versus 2 or 3 centimeters inside the right atrium. And the effluent dose of the patient was much better because blood flow was much better as well. And you had no side effect like a rhythm disturbance of thrombosis of something like this. You have to use obviously soft catheter. You might not do this with hard catheter. You have to be very cautious, but all the new catheter nowadays are soft one. But this has been done since 15 years, 1-5, in the chronic dialysis setting. I'm also a nephrologist. So, as Thomas said, the flow is so huge, no problem. And you are in the large cavity in the body. That's wonderful. I haven't said 7 centimeters. I said 2 to 3 centimeters, soft one. Okay?
So, Patrick, I understood. You recommend to place the tip of the catheter inside the right atrium?
Yeah. Coming back from the story of the chronic dialysis patient, we do this all the time. But you need really very soft catheter.
Yeah, because the risk, why do people place the catheter at the entrance and not inside the right atrium? What's the risk? In the past, the risk, the theoretical risk, is that the atrium is hitting the tip of the catheter, and then there will be like rupture of the wall of the right atrium, right? Imagine your atrium is hitting the wall like this, the tip, and then the risk is the rupture of the wall of the atrium. But as Patrick said, now the catheter is very much softer than before. Polyurethane, silicone, it's okay. And then I think this risk is now minimal, right?
Exactly. And in the recent study published last year, another one, just exactly the same rate. No more, no less.
Okay. So there is one country where they do this a lot. They place the catheter in the right atrium. It's in England. In England, they place the catheter in the right atrium, right? Do we have people from England here? Do we have English?
So if it's better, if you get better flow and better dosage in the right atrium, would you then use a 15 centimeter catheter from the right IJ to have a better chance of ending up there?
You mean 15 or 20? 20.
20 centimeter catheter.
That's a very good point. We have a big guy of 1 meter. Maybe we should use 20 centimeters. The guy you have, but I fully agree. Yes, another question?
I'm sure we all take care of very sick patients who have all sorts of vascular issues. So it's not abnormal that we can't use the femoral line and we already have something in the right IJ. If someone has, they're a bad vascular path and they have a large EJ instead of an IJ, is that something that you guys would support using instead of using the subclavian?
The question is, can you put the central line and the catheter, the dialysis catheter, in the same line, right?
This is possible. I mean, at some point, if you can make sure that your 20 centimeter in the left one, even 25, is going deeper, might be the dialysis catheter, and then you have your center line, 15 centimeter, on the right side. But you have to make sure on the chest X-ray that there is a difference of 3 to 4 centimeter to repeat the shotgun approach. Okay?
But I've seen also in some centers, not in France actually, but abroad, and again in UK, sometimes they place both lines, the dialysis catheter and the central venous line, in the right jugular vein.
Okay, another question here.
Yeah, thank you. If we have like alarm in our CRRT machine, excessive line, actually I still use the switch line for that. So which one do you prefer, to remove the line, insert the new one, or just switching it because the recirculation?
No, yeah, you should not switch your lines. Switching the lines, it can be dangerous for your patient. Why? First, because you are going to under-dialyze the patient. As I said, the recirculation rate will be 45%, 50% if you do so. The other problem is, why do you want to switch your line? Sometimes it's because you have like a pressure problem, right? Usually it's because when do you like an entrance pressure, very negative,
yes,
right?
Yes.
Oh yeah, it's always very negative, always very negative. So you switch lines and then it can fix your problem. Usually it doesn't fix for a long time. Just you gain a few hours. Okay. Why sometimes you have to think, why do I have this very negative pressure? Sometimes it's because you have a small clot here, right? You have a small clot starting to be formed at the entrance of your catheter. And so you have a negative pressure. Then you switch the lines. The blood enters here and then exits here. The clot is pushed away here. How do you call this? What is it? You send a clot to the circulation. This is a pulmonary embolism. Do you want to do pulmonary embolism no? So that's why I think it's better to change your catheter instead of switching the lines. Yeah. Wait. Sorry, I didn't know.
Do you think that rewiring catheters, if you've got a problem with a catheter, putting a wire down and putting another catheter down, is it a worthwhile exercise, or should you just put a whole new catheter in?
Okay, I was expecting also your question. So the question here, I think, if I understand correctly, do you have catheter dysfunction? Do you perform a guide wire exchange, or do you switch for another site? If you do a randomized controlled trial and you compare, and then the outcome is the new catheter dysfunction, then it's better to switch. If you can switch for another site, it's better. But sometimes you cannot, right? Sometimes you cannot switch because other sites are occupied. Then you do a guide wire exchange. But guide wire exchange, you have to do it in a clean way, right? Because you have two techniques to do the guide wire exchange. One is clean, one is dirty. And I think when I was a fellow, I was doing the dirty thing. You put your guide wire in the here it's dirty, right? So if you put like a sterile guide wire here, you take the bacteria here and you put them inside the body, right? Not so good. So there is a clean way. Look, you have your catheter here. So you put, so this is dirty, right? This is dirty. You all agree? So this is a dirty hand. This is my nurse. We remove a little bit and this is a clean section. Then my hand at the left, which is clean, I clamp here. I cut the catheter here. All the dirty part is getting away. I place a new drip here. And then I put the guide wire in a clean section. So I don't put bacteria inside the circulation. Okay, so you have to pay attention to put your patient in a good position to avoid pulmonary embolism here. Because at that moment, here, theoretically, there is a risk of pulmonary embolism, but if you place the head below, then it's okay. So you have to pay attention to this risk and to do it in the right position. But then if you do it in the right position, it's very clean to do it in this way.
Okay, we have now 42 minutes in total, so we have to stop here. I wish to thank again Thomas and also the audience for really a lot of questions. And so enjoy the whole symposium, and thank you so much for your kind attention and for your numerous questions. It was really very interesting. Thank you.